new treatments for IPF, although I think the title might have said pulmonary fibrosis in general. Happy to have a discussion at the end about sort of alternative diagnoses. This is really just going to be my musings on what's happened over the last 12 months or so. I've had no relevant disclosures apart from a couple of Christmas cookies recently. So today I'm going to talk about questions that arise from clinical practice. We've been using a couple of drugs, antifibrotic drugs now for a little while, and there are plenty of things to talk about with respect to how we use them. I'm going to talk about a couple of patient-centered endpoints or results from recent trials, non-pharmacotherapies, and then emerging treatments right at the end. So key events in the last sort of 12 months or so, both pirfenidone and nintedanib listed on the PBS around the middle of this year. And that obviously is practice changing for a lot of our patients. And the other thing that's really important, I think, and I encourage everyone who hasn't already to get hold of these, are the recently published position statements, both for treatment of idiopathic pulmonary fibrosis and also the MDM relevance in the local setting. Just to remind you, the PBS criteria for provision of antifibrotics. So MDT diagnosis is absolutely mandated, and we'll talk about this a little bit later. Otherwise, the criteria are really largely based on the clinical trials for both drugs, excepting that the FVC has to be above 50%, but there is no upper limit of FVC, which I think is important, and I'll mention a little bit about that in a second. There has to be no other obvious cause, and again, we can talk about sort of those complex patients who may have features of other diseases but not diagnostic for, and whether you treat them or not. So the way I think about this is kind of the who, when, where, what, and why of antifibrotic therapy. So who are we treating and the timing of that treatment? Do we treat them at the time of diagnosis? Do we wait for evidence of progression? Why are we treating this and what are the endpoints? Are we trying to improve symptoms? Are we trying to improve mortality? Are we trying to modify disease? And where are we treating these patients? So what is the best environment for best outcomes? So to remind you, the trial data for both drugs essentially shows a 50% reduction in rate of decline or loss of FVC, and that was over a 52-week period for both agents. And it is for mild to moderate. So that means FVC above 50% and DLCO above 30%. What about these patients with earlier stage disease? Do we need to treat them early or can we watch and wait? Just to remind you about staging of IPF. So the most simple and the most widely used and a valid endpoint is FVC. So less than 50% severe disease, above 50% mild to moderate disease. Remember that patients can have a normal FVC at the time you see them, but that FVC can have dropped significantly from previous that has not been measured. So just because the FVC is 100% predicted at the time you see them doesn't mean that they don't have progressive disease. There are plenty of other clinical staging tools available. The gap index is probably the most well validated and is now featuring as an endpoint in some of these clinical trials. And essentially it is gender, age, and then some physiologic parameter. And you can sort of add these tools together as well to get a sort of more composite endpoint. The good thing about FVC is that it does separate, the gap index, my apologies, is that it does separate out quite nicely mortality. And so in these early stage patients, gap index 1, you can see that mortality even at 3 years is pretty low. And you might consider that for these early stage patients, perhaps a watch and wait approach is reasonable. There is some evidence, however, to the contrary. And I will tell you now that a lot of this data that I present today is going to be post hoc analysis of the large clinical trials for both of these agents. So the numbers are big, the trials are rigorously conducted, but it is all post hoc analysis. These are not necessarily primary endpoints. So for the pirfenidone studies, Capacity and Ascend, there was a post hoc analysis done looking at patients who were stratified by disease severity, either by FVC or gap at baseline. remember that these studies had FVCs up to 90%. So patients who had FVCs above 90% were excluded from trial enrollment at the start. And they followed these patients for efficacy and safety for a further 12 months. And the parameters used were FVC, 6-minute walk, and shortness of breath. And so what we can see here is that, on the forest plots, that for more or less severe disease, so above or below FVC of 80%, there is no difference in terms of further decline of 10% or more over the ensuing 12 months. And the same applies to the gap index, so whether they're stage 1 or stage 2 or 3, there is no difference in how these patients behave. So they both progress similarly, severe or less severe disease. And furthermore, in the patients who were treated, losing control of this thing, maybe I should use the pointer. In the patients who were treated, whether they had more or less severe disease, either by FVC or gap, there is benefit and equivalent benefit with pirfenidone treatment over placebo. The same doesn't necessarily apply for the other indices, so 6-minute walk distance and breathlessness are probably not improved for the milder disease, but perhaps more so for the more advanced disease, for breathlessness, and similarly for 6-minute walk. However, there is a significant benefit from treatment with pirfenidone in early stage patients when compared with more severe disease. There is similar data for nintedanib as well, and this will be a recurring theme throughout this talk. So again, pooled post hoc analysis from the 2 Impulsa studies showing that patients, stratified for patients who had an FVC at entry of more than 90% versus less. And I think it's important to note that a quarter of patients in these studies were considered mild disease at the time of entry. And they looked at further decline or death as a composite endpoint, and also time to exacerbation over the following 12 months. And you can see from this graph that in the placebo-treated patients versus the nintedanib-treated patients, whether they had FVC above or below 90%, there was no difference, but of course a significant difference in the treated patients compared to placebo. So again, you can feel confident to say that in a mild patient, they will still get benefit from treatment in terms of further disease progression. So what about the alternative? What about severe disease? These are all patients who are excluded from the clinical trial. So these are FVCs less than 50%, DLCOs less than 30%. There is very little data in these patients. There are some cohort studies which have suggested that potentially those patients who are rapidly progressing and have more severe disease actually derive more benefit from treatment, but this has not been studied prospectively. And so as yet, we don't have a definite answer for this. There is a currently recruiting study looking at nintedanib alone or in combination with sildenafil with a breathlessness endpoint on the assumption that the pulmonary vasodilation improves breathlessness in these patients. And this trial is recruiting patients with severe disease, so we may get some signals from the nintedanib alone arm as to whether it's beneficial in this subgroup. So one of the other main clinical questions that we face all the time is which drug to choose. So both of these agents have really similar efficacy in terms of the primary endpoint, which is FVC decline over 12 months and hopefully beyond. We know from pooled data recently published that pirfenidone reduces all-cause and IPF-related mortality up to 120 weeks. So these are from the pooled data from Capacity and Ascend. And we know from the nintedanib data that there is reduced time to first exacerbation and exacerbation rate with the treated patients compared to placebo. However, we don't have any head-to-head comparisons as yet. And so I think a lot of the decisions around drug choice come down to side effects and how they affect your individual patients. So upper versus lower GI, skin, Drug interactions, so for example, anticoagulation is contraindicated in nintedanib-treated patients. And the dosing schedule, and some patients don't like taking 9 tablets a day, they'd prefer to take 2. So these are all discussions that you have in the clinical setting. But the ultimate decision about which drug to choose will come down to you and your interpretation of the data. There is some recent data to suggest that pirfenidone reduces hospitalizations, and so this comes down to sort of patient-centered endpoints. It's hard to have this discussion with your patients to say, oh, we're going to sort of stop the rate of, stop your FVC declining as quickly by giving you this drug, but it's going to cause you diarrhea. And I think you do have to have this discussion with your patients about things that they will experience that will actually make them feel better. So reduced hospitalizations is one. Symptoms would be another. Symptoms, I think, is trickier to sort of prove. But certainly for respiratory-related hospitalizations, again, pooled data from pirfenidone studies, there is a benefit for treatment versus placebo. And there is also some recent data presented this year at ERS looking at extension patients on the Impulsor study. So these are patients who have been continued on treatment or started on treatment after the initial 52-week period. And I think this is reassuring to say that longer-term treatment out to 144 weeks beyond the initial 52 shows really that these two slopes are very similar. New treated patients and continued patients do as well as each other and certainly better than untreated patients. And there was really no new safety signals for extended treatment. Similar rates of diarrhea for nintedanib, which is really the big one. Weight loss is also a concern, and they were similar in the continued patients. So what do we do in patients who progress on treatment? So you've got a patient, you've got them on treatment, at 6 months the FVC is dropped by 15%. And these are your options, I think. So you continue them on the current treatment, switch to an alternative. Having 2 drugs that are equally accessible from a funding perspective, I think is a real advantage in this country and doesn't apply everywhere. Is there a role for combination treatment? When do we think about enrolling our patients now in clinical trials, given that we have 2 potential treatments to treat them with? So again, pooled pirfenidone data, and this is looking at early or late progressors in the placebo-treated patients, in the pirfenidone-treated patients who had lost 10% or more of their FVC either in the first 3 months or in the subsequent 3 to 6 month period following initiation into the clinical trials. And the outcome here was obviously further progression or stabilization or death. And you can see that in patients who were on treatment who had progressed within the first 3 or 6 months, the numbers of further progressors was significantly lower than those patients who remained on placebo. And in fact, the majority of patients stabilized, so did have no further FVC decline over the ensuing 6 months. So even in patients who progress on treatment, you can feel confident that continued treatment in the majority will cause stabilization. And in fact, there was a slight increase in FVC, which was significant over the placebo-treated patients in the ensuing 6 months. Similarly, in patients on nintedanib treatment who progress at more than 10% in the first 6 months of therapy, the majority of those, and very similar numbers, stabilized or did not progress further over the ensuing 6 months. I think it's important to note, however, that the numbers of patients who, and these are small, but the numbers of patients who did progress with a further 10% reduction was similar in the placebo and treatment arms. So combination therapy really has no efficacy evidence at this point in time. That's not to say there aren't patients on both drugs, but at the moment we don't have any evidence to support this practice, apart from the fact that, in principle, it's biologically plausible and the treatment appears to be well tolerated, with some drift in gut toxicity, particularly upper GI toxicity. So there are two studies, one pirfenidone first add-on nintedanib, the second is in Journey, which is nintedanib first add-on pirfenidone. In both of those trials, the rate of nausea and vomiting and dyspepsia was significantly increased compared to monotherapy. And there's a bit of pharmacokinetic variability, but no huge signal that the pharmacokinetics of one or other drug is grossly disturbed. There's no efficacy data to date. So this other question arises about what happens in patients who don't have definite IPF. And so this is the ATS-ERS diagnostic criteria. It's from 2011. We're talking about this group here. So basically those patients who don't have honeycomb change and don't have traction bronchiectasis, but otherwise have what looks and feels and smells like IPF. What do you do about those patients? They don't want to have a biopsy, they're too risky to biopsy, you can't get any additional evidence to support your diagnosis. We do have a little bit from the nintedanib studies, and they did have 200 patients in the initial trial who had at best possible UIP. So they didn't have a biopsy, and there was no other evidence to support a diagnosis of IPF. And you can see that the difference from treatment to placebo versus those who had definite IPF was quite similar. So in fact, if you've got possible IPF, you could probably treat these patients successfully with antifibrotic therapy and avoid the need to sort of force them to have a histopathologic confirmation. This concept extends to other fibrotic lung diseases. So there's this concept of progressive lung fibrosis as a sort of biologically common endpoint of a number of chronic interstitial lung diseases. And I think that all of us see this. Connective tissue disease patients who have UIP pattern on CT scan, unclassifiable, this is after MDT discussion, and up to 15% of ILD patients will still be unclassifiable at the end of a multi-D discussion. This is idiopathic pneumonia with autoimmune features, so these are patients who have some low-level antibody positivity but don't have an autoimmune or connective tissue disease diagnosis, and idiopathic NSIP. I think that there is biologic plausibility for using antifibrotic treatment in these patients if you assume that the endpoint or what's happening in the lungs is similar for all of them. And there are some currently recruiting studies specifically looking at these questions. So there's a pirfenidone unclassifiable study currently recruiting. I think this had an Adelaide site of recruitment, and I think that study might have just closed. So this is systemic sclerosis with UIP and nintedanib monotherapy. And then there's an ongoing treatment for progressive fibrosing phenotype, which is really all comers but not IPF. So I think this is watch this space. Okay, so disease behavior in IPF. I mean, we know that the median survival is poor, but I think it's interesting if you look through the literature, the often quoted sort of 2 to 3 year median survival is probably changing. And while it's not changing dramatically, it is going up. And this is probably for a couple of reasons. So this is from some Canadian data recently published. Pirfenidone's been available since about 2008. And I think we've got a lot better between then and now at classifying these diseases accurately. So I think we're calling IPF, and we're not including more sort of acute or rapidly progressive disease in this cohort. Having said that, we all know this, and we all see these patients, who stay stable for a very long time. I get referred patients who have IPF, who have had it, if you look back through their old CTs, for 8, 10 years. And then we all see these patients as well, who sort of go from symptomatic presentation to death within 12 months. So how do we predict disease behavior in this condition? I'm not going to go through all of the data because there's a lot, but just to highlight a couple of sort of current points, really. So this was a study that looked at baseline physiologic markers, and this is a bit like the gap index really. So these are pooled data from 6 studies, followed up for 60 weeks with a mortality endpoint, showing that baseline older age, smoking status, more severe disease, so FVC becomes relevant, as I said before, and also gas transfer at baseline are predictors of mortality. But more significantly than that, significant decline in FVC more than 10%, and exacerbations more than anything, although the confidence intervals here are really wide, were the strongest predictors of diagnosed patients and how they would progress or behave in the ensuing 60-week follow-up period. How can we identify these patients more accurately? And there are a number of ways of doing this, and none of this is necessary in clinical practice, but I think it's interesting to be aware of it. So gene risk profiling is pretty hot at the moment in a number of areas, and this is no exception. So this was an interesting cohort study across North America and Europe, and they had this 52 gene signature from mononuclear cells obtained from peripheral blood that they'd previously validated, and used a scoring algorithm to determine risk status for mortality and time to transplant, and basically used it as a binary function, so high or low risk, and really showed quite nicely that using this gene signature, you can separate out high and low risk patients and predict mortality. And further than that, when added to the gap staging index at baseline, there was a significant improvement in your ability to predict time to transplant or mortality in these patients. So there are other ways of sort of predicting disease behavior, and one of the other areas of interest has been peripheral biomarkers, so epithelial biomarkers. Probably the two best known are MMP7 and surfactant protein D. What has become apparent really is that an individual biomarker is not going to be sufficient in isolation to tell you enough about how this disease is going to behave. And so people are looking at, or groups are looking at combining these biomarkers to give you a better and a more accurate risk predictor. So this was a study that had a 2-stage design and identified a panel of 4 biomarkers when used together, showed significant association with disease progression and also mortality. And these two are obviously cancer markers that we use commonly. They're easy to measure, they're cheap, and showed quite significant benefit in terms of their abilities to predict disease progression and mortality. So again, this is something to watch, but I think this is really where the future is. And what we're talking about here is being able to really pick those patients who are the flat line, the people who are not going to progress over a long period of time, and the ones who you could genuinely potentially say, we can watch and wait. But up until then, I don't think we can. 1 minute? Okay. We'll do our best. Okay. So, where should we manage these patients? As I said at the start, the Australian, so the TSANZ has recently published a position paper on this issue, and I think everyone should read this. Essentially, the evidence for expert opinion or expert sort of diagnosis comes from some older papers. So the K values are -1 to 1, the kappa values, and they tell you about sort of inter-observer agreement. There's a clear difference between community clinicians and experts in terms of their ability to diagnose IPF. There's a clear sort of increase in agreement when you add more people into the mix. So this is a sort of full-blown MDT. And this is a recent, I'm sorry, all the references have dropped off the bottom. This is a recent publication from Helen Joe looking at whether it matters, and in fact it does. So these were patients who were referred with a diagnosis of ILD to an MDT clinic, and you can see that there are significant differences in unclassifiables becoming classifiable by the MDT input, in CTD-ILD, which goes up significantly, and in hypersensitivity, which does as well. So the harder to diagnose ILDs are better done by an expert group. While there's no difference here, in fact, 10 of the 27 who were referred for IPF didn't have IPF, and 8 did. So there is a substantial difference in diagnosis and therefore treatment and management in patients who are done through an MDT. Of course, there are implementation issues. So how do you standardize the meeting? What do you collect? How do you deliver the results? And probably more relevant in some ways is how do you access these meetings? So not everyone works in a tertiary hospital where they have ready access to an MDT. That's a point for discussion. I think a lot of that revolves around telemedicine and linking in and so forth. And the private sector is the other sort of unknown in that sense. I've got a bunch of other stuff to go, but if you want, I can cut it short. You tell me what you think. Yeah, okay. All right, I'll whip through it. So, I just wanted to make a point about acid-suppressing therapy because it is currently conditionally recommended in all the guidelines. And that seems reasonable and is biologically plausible. However, there is a little bit of data from, again, post-hoc analyses, so nintedanib and pirfenidone studies, that really there was, so 38% on baseline treatment, no impact. And here, similar, but in fact, for the more severe group, I forgot to overall and pulmonary something, okay, insert word here. The outcomes were worse in the more severe group in antacid treated patients. So this sort of blanket approach to putting everyone on antacid treatment may not actually be the right thing to do. We've got to just be a bit careful about this. Statins and IPF, similar sort of analysis and potentially some benefit in terms of the statin-treated patients when corrected for cardiovascular risk factors. Cough is common. There's evidence for thalidomide. It's very poorly tolerated. 75% of patients had intolerable side effects on the randomized placebo-controlled thalidomide study. There's a very recent publication looking at sodium chromoglycate inhaled in a high concentration formulation delivered via a nebulizer. Objectively, using the Leicester cough monitor, there was at 2 weeks a significant improvement or reduction in coughs per hour. These are high numbers though. Imagine coughing for 57 times an hour. Unfortunately, the subjective measures, which were secondary endpoints, were not positive in this study, but this is something to watch. Old treatments for disabling symptoms in these patients. Pulmonary rehab, let me just whip through that. So this was again from Leona Dowman from Melbourne, published recently in Thorax on exercise training in interstitial lung disease. And sort of had a mixed group of patients, about slightly less than half with IPF. 66% sort of completed the 8-week program and demonstrated overall improvement for the whole cohort, but most significantly for the asbestosis group and least significantly for the CTD group. IPF did okay at sort of 9 weeks, but then sort of drifted back at the 6-month follow-up mark. And so again, where does pulmonary rehab fit into this group? I think there's definite benefit, but maybe it's not sustained as we see in some other chronic lung diseases where there is sustained benefit at 6 months. And so maybe some thought about how we evolve or change our rehab programs. I will end with this. So emerging therapies. I think this is really important in terms of understanding the biology of this disease when you're thinking about what's coming next. So we've changed a lot about how we think about IPF over the last really 10 years or so in terms of the genetic sort of predispositions, in terms of the cells that are important, the inflammatory or fibrotic cytokines that are important, so beta 1, the alveolar epithelial cell, and this concept of autonomy or fibrotic behavior that is a bit like cancer. So it's sort of self-driving and no longer requiring of insult or injury. And so when you think about what are the targets of treatment, right now we're looking at the endpoint, which is fibrosis. What we should be doing is looking higher up the pathway. And in 10 years' time, we're going to be treating with 4 or 5 different drugs, different levels of this sort of pathway to try and get better results for our patients. I'll leave it there. Apologies for going over time.